Welcome everyone to this video recording on heart failure. We're going to be going through the pathophysiology related to heart failure. We're going to go through some of the causes, the symptoms, and of course what we're going to focus on is the physical therapy management, though we will also touch on diagnosis and surgical management of heart failure. I'll refer you to the really excellent reading in the O'Sullivan and Schmidt's textbook as well. So just as the name implies, heart failure is a failure of the heart to meet its goals or its job in the body, which is to make sure that it's delivering enough oxygenated blood to all the tissues to meet metabolic demand. And so the physiology, the pathophysiology of this is really pretty complex. It is treated, as I mentioned a little bit in the textbook reading, so I'd encourage you to read through that. But basically, either it's a failure of the ventricles to pump blood. So, for example, if someone has consistent peripheral hypertension, high blood pressure, the left ventricle is having to constantly work really hard to pump blood out against that high resistance in the periphery. Over time, that's going to wear the left ventricle out, and so that can cause heart failure. Similarly, when we've talked about some of the pulmonary pathology issues before in the pulmonary unit, we talked about that the pulmonary disease can cause hypertension or increased resistance in the vascularity through the pulmonary system. So the right ventricle, of course, is having to pump blood out through the pulmonary circulation, and if it's pumping against high resistance, it also could wear out. So that could be another reason. So basically, the ventricles can't pump out enough blood. There could have been a heart attack that damaged part of the ventricle. That could also leave it unable to pump enough blood. The other reason, though, would be that the ventricles can't relax enough to fill with enough blood to be pumped out. So the pumping itself might be okay, but if the tissue, again through either damage or through atherosclerosis, has become very stiff, the ventricles can't relax, can't fill with blood when the atria contract, and so then there's not really that much blood to pump out. So again, that would result in a failure of the heart to be able to provide enough oxygenated blood to the tissues to meet metabolic demands. So here's an example or an illustration. So remember, systole is when both ventricles contract, the right ventricle pushing blood through the pulmonary circulation and the left ventricle pushing blood through the peripheral circulation. So they both contract, pump blood out. So in systolic heart failure, we have usually an overfilling of the ventricle, but then a weakness or an inability to contract and to empty that blood out. What you're seeing on the far right is cardiomegaly. Because over time the ventricles have been working harder and harder, the body said, hey, those ventricles need to be stronger, so we're going to increase the size, hypertrophy that muscle so that it's stronger. So over time you end up with this hypertrophied ventricle, but it still really can't pump out the blood. It's ineffective. So I think we've covered some of the causes. Certainly coronary artery disease, as I mentioned, either repetitive ischemia or an actual MI could cause damage, or it could just be result in asynchronous firing, and that won't allow the ventricles to contract. I already mentioned systemic hypertension and pulmonary hypertension. You might remember the term for heart failure from pulmonary hypertension is called cor pulmonale. We actually covered that in the pulmonary unit. One thing I didn't mention was valve dysfunction. We talked about valves way back in the anatomy and physiology lecture, and if you look at the valves between the right and the left ventricle, if that valve is faulty, when the right ventricle contracts, some of that blood, remember, will squeeze back up into the right atria instead of going out through the lungs. Similarly, if the mitral valve is faulty, when the left ventricle contracts, instead of all that blood going out through the aorta, some of it's going to backflow back up into the left atria. So that heart failure or valve dysfunction is a pretty common cause of heart failure. And then there always are people who have congenital heart disease. And so you could see heart failure in a younger person, but by and large we're going to see that in an older person. So the symptoms, of course, are going to be decreased activity tolerance. That's one of the major issues, is that the heart is not able to meet the demands, especially of higher levels of activity or function. This causes dyspnea and tachycardia when the person does try to do more activity because they're lagging in the oxygenated blood delivery, so they're going to get short of breath. The heart rate's going to try to increase to compensate, but it usually can't compensate enough. People do experience a lot of fatigue, and some of that fatigue is due to just the low activity tolerance, but some of it is due to some of the symptoms you're going to see in a second related to skeletal muscle myopathy. Pulmonary edema and peripheral edema are really big symptoms, and they're ones that in physical therapy you have to pay attention to. I know we've talked about this before, but a lot of people don't look at people's legs as much as we do. So we're going to be seeing their legs. We're going to be noticing when they tend to have rapid changes or big increases in their lower extremity edema. And so typically we're looking, knees down, often kind of around the ankles and the feet. People will complain they can't get their shoes on, or that their feet have swollen a lot in the last couple days. Pulmonary edema, we see that coming through. We can hear that. Remember the crackles and the rowels? That's the noise that air makes as it's moving through alveoli where there's pulmonary edema sitting in there. And then finally, skeletal muscle myopathy, skeletal muscle damage or disease. A couple of reasons for this. We definitely have less oxygenated blood flowing down to those working muscles, and so the body is going to sense that, and it's going to say, hey, we need more vasodilation, and it's just not going to be able to serve those muscles. Because of the lack of oxygen, you're going to have less muscle metabolism, and that causes atrophy of both type 1 and type 2 muscle fibers. So we definitely see muscle atrophy as well as disuse atrophy. So there's kind of a downward spiral. We have chemical changes that occur because of the heart dysfunction, but then we have long-term disuse changes occurring because of lower and lower levels of activity tolerance. So you're going to see strengthening, muscle strengthening is an important part of what physical therapy needs to do for patients who have heart failure. For diagnosis, really simple and easy thing to do is to listen to the heart and lungs. So listening to the heart will allow the practitioner to hear a murmur or the swishy sounds that occur when there's valve dysfunction. It will also allow, listening to the lungs, then, as I mentioned, allows them to hear the crackles and the rowels that occur as the air is moving through the pulmonary edema. EKG, as you're aware, we've talked about this before, can give us a lot of indications of abnormal function in the heart, and we could certainly have the person undergo a stress test. So those are some ways. One of the ways that we detect some of the chemical changes that occur due to heart failure is through a blood test called the BNP. And this determines the presence of a peptide that kind of secretes from the ventricles when heart failure is exacerbated or getting worse. Really common way to do it is a chest x-ray. And so here's a normal chest x-ray. And what you're looking at is just the proportions here. So the width of the thoracic cage, and then you can see the width of the heart, and you can see the shadow of the heart. And it might surprise you. It's kind of a weird shape when you look at just the silhouette like that. But remember, it doesn't really look like a valentine. We have the front, what we're looking at in the front is mostly the right atrium ventricle, and then what you kind of see bulging off here on the left side of the patient, but the right side here is the bulk of the left ventricle. So anyway, this width should not be more than half of the width of the thoracic cavity as a whole. So if you look here at a patient with cardiomegaly or an enlarged heart, you can see that the width of the cardiac silhouette is more than half of the diameter, is more than half of the diameter of the thorax, or is more than the hemithorax. So this again would be a typical way. They also could see pulmonary changes as well. Another thing that's very common to do for heart failure is an echocardiogram. And we looked at that when we looked at stress tests. It's an ultrasound that shows up on video, and it allows us to look at the movement of blood through the heart. And from that, we can calculate an entity called the ejection fraction. And if you think about the amount of blood in the left ventricle, when the left ventricle contracts, a certain percentage of that blood is going to be ejected, not all of it. So normally, about 55 to 75% of that blood is ejected from the heart with every contraction of the left ventricle. So an ejection fraction is an indication of how well the left ventricle is doing at getting that blood out and delivering it to the rest of the body. So often in physical therapy, I've seen patients with ejection fractions down to 25 and 30%. So those people have very low activity tolerances. And if you're seeing somebody with heart failure, you should see if they've had an echo done and if they have an ejection fraction listed, because it'll really give you a good sense of what their current functional status is. What I have listed here then is the New York Heart Association's functional classification for heart failure. So when we're looking at a diagnosis, this is based, just as I said, on a functional classification. So this is something you should be able to see, like from a cardiology report, for example, for a patient with heart failure. If they don't have it, though, you could probably estimate it. So class 1, really they have no limitation of physical activity, and ordinary activity does not cause fatigue, and so they are able to function up to about 6.5 METs. And if you remember, 6 to 9 METs is kind of pretty normal, functional, vocational and household types of activities. Class 2, slight limitation. They're comfortable at rest. However, just normal, typical activities will give them a little bit of shortness of breath. Class 3, they have pretty marked limitation. They're still comfortable at rest, but their max output is about 3 METs. So if you remember, 1 to 3 METs is going to kind of be your typical ADL or kind of very light household activities, sitting, using a computer, that kind of thing. And then finally, class 4, of course, is the most serious, where they actually have these symptoms at rest. They're short of breath at rest, and dyspneic on exertion, and so they are only able to get up to just a little bit over 1 MET, which is, of course, normal, just sitting and resting. Now, I'm not going to ask you to memorize this scale, but I do think it's a good way to think about people's functional status in relationship to their heart failure. In relationship to surgical management in people who have really serious heart failure, they have what's called a left ventricular assistive device. And so basically, they just kind of add another left ventricle. You can see that the tubing goes, really takes the blood right out of the left ventricle and pumps it right up back directly into the aorta. So, I mean, it's kind of a major bypass, bypasses the left ventricle altogether. There is a little pump, so you can see there's a little control system, a little battery pack, so the person can be ambulatory and moving around. And I know some people who have done clinicals at the VA in Madison have seen people on the left ventricular assist device, particularly people that have been waiting for heart transplants. So that's another option. A person with heart failure could get a heart transplant, or they could have a pacemaker implanted. We are going to talk about pacemakers in another video. So what I want to focus on right now then are the benefits of exercise for physical therapy management. There has been a lot of literature in the past 5 to 10 years done on the benefits of exercise for people with heart failure. And I think one of the first questions they wanted to answer was, is it dangerous to exercise people? I think that's a pretty logical question, because you have here a condition where the heart isn't able to supply the needs of the body, sometimes even just a little bit above rest. So the thought of exercising people is a little bit scary. And so they did a number of studies, and then there was a big Cochrane review which reviewed all those studies in a big mega-analysis, and they found that there is no increase in mortality rate when patients participate in supervised exercise routines. So of course our first obligation to the patient is to do no harm. So they definitely assessed that exercise did not harm the patient. further, of course, we want to do good. And so they found that there's a decrease in hospitalizations due to heart failure. And for any of you who've been in an acute care setting for a while, I can tell you the hospital I practice in, recurrent exacerbation of heart failure is a big reason we see the elderly rehospitalized. So that's a huge thing. And then finally, it definitely increases the quality of life because it improves their functional capacity. So we have very good evidence that exercise is effective and appropriate. So as far as our making sure that we are exercising people at the appropriate level, we have a variety of ways of assessing that. We could use our typical heart rate reserve formula, which you've done many times, and the target percentage could be as low as 55 up to 80%. Now, sometimes that seems too dramatic, so another way we could do that is we could do a 6-minute walk test, which basically is just that. You have somebody walk at their own pace for 6 minutes and take their heart rate at the end of that 6 minutes, and so that can be their target heart rate. The other way to do it is just to take their heart rate at rest and then add 20 to 30 beats a minute. And if you remember back when we talked about cardiac rehab phase 1, when somebody's in the acute recovery phase after an MI or a cardiac bypass surgery, about 20 beats a minute over resting was our target. So any of those would be fine if you're using heart rate. Now the trouble is that often patients with heart failure are on a number of medications, including beta blockers, which blunt the response of the heart rate. So heart rate is not always a very reliable measure of intensity of activity with patients with heart failure. So we always have the Borg scale, the rate of perceived exertion, and our target there would be 12 to 14 or somewhat hard. Now remember, in somebody who's in a phase 1 or phase 2, they might get to feel like something is somewhat hard with very, very little activity. So those are a couple ways that we can look at intensity. When we're doing the aerobic portion of it, we want to still have our 10 to 15 minutes of warm-up and cool down with 20 to 30 minutes at target intensity. But I can tell you that I don't see a lot of patients who could tolerate that much activity at once. And so generally what you're looking at is progressing with intervals. So as soon as you do something, they're already at their, let's say we're using RPE, rate of perceived exertion. They're already saying it's somewhat hard. And they can do that for 3 or 4 minutes and then they have to rest. And then we would try that again for maybe 3 or 4 minutes and let the rest over the course of, let's say, a 30-minute physical therapy intervention. So very small, frequent bouts allowing them to recover, get back to baseline, which in itself could take a few minutes. So you may have to take a very slow approach to this aerobic exercise. We would, if I was seeing a patient like this, I would love to see them 5 days a week. We could see them 3 days a week and have them do it on their own for a couple of days, or just work it into their daily activities. You might be seeing somebody in a home care setting, so you may not have complete control over your frequency, but you're going to shoot for probably around 5 days a week if you can. I mentioned before that we also have a cardiac or skeletal muscle myopathy that we need to deal with, and so resistance exercise is really important. And it's probably pretty clear to you also that we need to be conservative. So we're going to start with a 20 rep max, determining their 20 rep max, but then minimize their repetitions to about 15 reps. So there's nothing magic about that. If they can't do 15 reps, you could cut it down to 10 reps. But you're definitely going to go on the low resistance, high repetition spectrum because, of course, we want to build endurance. So let's say that we were able to do that set of 15 reps. Then once they can do 2 sets of 15 reps at each level of resistance, then we're going to progress them. And we would want to ultimately get them to have their repetition maximum match with the level of reps that you're actually having them to do. So let's say, for example, you determined a 15 rep max. You would really want them to be able to do 15 reps of that exercise as their regular strengthening regimen. Remember when we do upper extremity exercise that does put increased pressure on the heart because it increases intrathoracic pressure. This makes the heart work harder, of course, and so we may continually stay at a little bit of a more conservative rep maximum in the upper extremities. So I may stay at that 20 rep max 10 or 15 reps when doing strengthening the upper extremities. We definitely don't want them to hold their breath, so encouraging a really relaxed routine where they take 3 seconds to do the concentric, then 3 seconds to do the eccentric portion of the exercise, assuming you're doing maybe open chain activities, I suppose even in closed chain. But you definitely want to avoid a Valsalva, so doing it in a really slow and controlled way is one way to avoid that. As with any resistance exercise, we're going to be doing this about every other day, so about 3 times a week. It's really important with somebody with heart failure that you're paying close attention to the vital signs. So we want to be monitoring heart rate, respiratory rate, oxygen saturation, pulse oximeter. We want to make sure, remember I said the heart rate sometimes isn't reliable, so you want to make sure you know if they're on a beta blocker, and we're going to address medications in another video, but make sure you know that. If their heart rate is dropping, that's a bad sign, so you want to make sure you let the physical therapist and the physician know that. That would tell you that their heart is not responding appropriately to the increased demand. Otherwise, you can look at rate of perceived exertion, respiratory rate, make sure that the respiratory rate stays below 40 beats a minute, since 18 to 20 is normal at rest. That's again about a 20 breaths per minute increase. And we always want to strive to keep their pulse oximetry above 90%. And remember to check with the physical therapist or the nurse or physician about use of oxygen in conjunction with exercise and activity. So a couple of things with somebody with heart failure that's really important for you to understand is we actually have precautions and contraindications to exercise. So people with heart failure frequently have AFib or atrial fibrillation as part of their past medical history. The only reason that would be a precaution would be if there's a new onset, or if this is a change for them, or their AFib is uncontrolled. Then you'd want to check with the physical therapist and the medical staff on if they're stable enough to do some activity. If their pulmonary status was worsening and it seemed that their pulmonary hypertension was very severe, that would give you a pause again, because that's, remember, going to make the right side of the heart work really hard. If they didn't have AFib or arrhythmia, but it came on with exercise, again, that would be something you'd be concerned about. Now, you wouldn't know this unless somebody was being monitored by telemetry, so you'd need to know that. And then certainly any unstable angina. Contraindications are very important as well. We often see people who have heart failure, and since we often see people with just a history of heart failure, we need to be able to recognize when that heart failure is exacerbated or increased to the point where it's not safe to exercise. So that would be the contraindications. No surprise, I'm sure, to you that a lot of these people have diabetes. Again, we want to make sure that's under good control. If they had another associated diagnosis of aortic stenosis, that could be a reason. So stenosis, remember, meaning stiffness or scarring. So that would mean the aorta can't expand, and so that would mean that it doesn't really matter what we do, they're not going to be able to get enough oxygenated blood to their tissues, no matter how much we exercise them. If they are in that condition where they can't tolerate more than 3 METs of activity, we can't really do exercise. I mean, 3 METs is pretty much the basics we need for some exercise activity. So that would mean those people who are in class 4 for heart failure, we wouldn't be exercising with them. And then critically here, you want to highlight this. These are the highlights or the signs of decompensated or exacerbated or an acute flare-up of heart failure. So if they've had more than a 2-pound weight gain in the past 24 hours, and if you're seeing them in an inpatient setting, they're going to get weighed every day. If you're seeing them in a home care setting, you may just have to try to monitor that with them. Other things, though, that they can tell you that are pretty easy is if they are telling you that they need more pillows to sleep. And remember that when they're flat, the pressure of the abdominal contents pushes up on the diaphragm, increases intrathoracic pressure, and makes it very difficult as well as if they have pulmonary edema. They're not going to be able to lie flat. So if they're telling you they need a couple pillows to sit upright to be able to sleep, that's telling you they've probably got some pulmonary congestion and their heart failure is in an exacerbation. Certainly if they're waking up and they're short of breath, that's something. If they have crackles or rales in their lung fields, they clearly have pulmonary edema. So those are things we want to be looking at. Something you may not be have heard of is called jugular venous distension. So the jugular vein, I think everybody knows where the jugular is, in the neck. What they're looking at is if the heart is failing, remember fluid or blood is going to back up into the vascular system. And so what we're looking at here is when the person's sitting at a 45-degree angle in that semi-Fowler position, we go from take a horizontal line right from where the sternal notch is, and then you go straight up about 4 to 5 centimeters, which is about 2 inches from there, and then you look at the jugular vein in the neck. And what you would not want to see blood backed up that far into the jugular vein. So this is what it would look like in a patient. So that almost looks like the sternocleidomastoid, but if you look up, it's not going the right way. It's not coming from the clavicle, and it's not going up to the mastoid process. That's where you'd see jugular venous distension. So this would be someone who you would not want to do exercise with. There's another picture of it. If a patient had a heart rate of over 100 beats per minute at rest, we've talked a lot about pulse oximetry below 90%, if their blood pressure was much higher than normal, and if they were not able to complete a 6-minute walk test of at least 300 feet. Oh, I missed fluctuating cognition. That again would just indicate we aren't getting enough oxygenated blood to the brain. So these are all really important signs and symptoms of heart failure that is gotten worse, and what that's telling you is they need to be medically stabilized before we can do exercise with them. Again, I can't emphasize how important it is for you to understand this, because this fluctuation can take place, on a daily basis, and we need to really be watching these patients carefully to make sure that we're not overexerting them. So at this point, what you're going to do then is complete lab activities 7 and 8, I believe, in your lab sheet, and then yes, lab activities 7 and 8, and then we'll be coming back together as a group and talking about them. You're strongly encouraged. Your book, your O'Sullivan-Schmick's book, is a great resource. You're encouraged to work together on those. But again, we'll come back together and discuss those together. So thank you very much, and we'll see you soon.